Welcome to the deep dive. Today we're getting into something really important, especially if you're grappling with diabetic complications or, revising for exams like the MSRA.
That's right. We're focusing on diabetic maculopathy.
Also known as diabetic macular edema. We want to give you a clear, sort of high-yield understanding of what it is and, crucially, how it affects vision.
Yeah, wading through medical info can be tough. So the mission today is clarity and hopefully making the key points stick.
Okay, let's dive in then. First off, what exactly is diabetic maculopathy?
Well, put simply, it's swelling and damage right in the macula.
A macula being that central bit of the retina.
Exactly, the part that gives you your sharp, detailed vision. And this damage, it's caused by diabetes.
Okay.
It's a really common follow-on from diabetic retinopathy. And the crucial thing is, if you don't catch it, don't manage it, it can really lead to significant vision loss.
So what's the root cause? What actually sort of kicks off this process?
It boils down to diabetes mellitus itself, especially, if someone's had it for a long time or if their blood sugar control hasn't been great.
Right, the long-term high blood sugar.
Precisely. That chronic hyperglycaemia plus related changes in blood vessels and metabolism, that's what causes the macula to, swell up. It gets leaky.
And who should be particularly aware of this risk? Are there specific factors?
Oh, definitely. Several things ramp up the risk. Having diabetes for many years is a big one.
Okay.
Poor blood sugar control, as we said. High blood pressure, so hypertension.
Mm-hmm.
Also, dyslipidemia, that's abnormal levels of fats like cholesterol in the blood.
Right.
And importantly, already having some level of diabetic retinopathy makes you more susceptible. Oh, and also having diabetic kidney disease.
That is quite a list to keep track of. Any easy way to remember those?
Well, we could try a mnemonic, maybe. How about LPHDRK?
LPHDRK.
Yeah, for long duration, poor control, hypertension, dyslipidemia, retinopathy, and kidney disease might help it stick.
LPHDRK.
Got it. That's actually pretty useful. So let's get into the mechanics a bit. What's happening inside the eye? The pathophysiology.
Okay, so fundamentally, that persistent high blood sugar starts damaging the walls of the tiny blood vessels in the retina.
Weakens them.
Yeah, weakens them, makes them less effective. And this leads to a breakdown of what we call the blood-retinal barrier.
Okay.
You can sort of picture this barrier like a tightly sealed pipe system, normally keeping fluid contained. But under the pressure of high blood sugar, it starts to fail. It springs leaks.
Ah, I see.
So fluid and lipids, like fatty stuff, start seeping out of the vessels and into the macula where they shouldn't be.
And that causes the swelling.
Exactly. And it's not just a leakage. There's also inflammation involved. And this molecule called VEGF, vascular endothelial growth factor.
EGGF.
Yeah, VEGF basically signals blood vessels to become more leaky and even grow abnormally sometimes. So it really contributes to the problem. That paints a clearer picture of the leakage. Now, if someone presents with these vision issues, could it be something else? What are the main differentials?
That's a really important question. Yes, other conditions can look similar. Key ones to think about are age-related macular degeneration, or AMD.
Right, common in older people.
Yeah. Also, retinal vein occlusion, a blockage in one of the retinal veins, and just other diseases affecting retinal blood vessels.
So how do you tell them apart?
It usually comes down to the patient's history, the specific symptoms, the findings on the eye exam, and specific investigations. Like a retinal vein occlusion often has a much more sudden onset than diabetic maculopathy typically does.
Okay, that makes sense. So we know what it is, what causes it.
Mm-hmm.
How common is diabetic maculopathy, let's say, here in the UK?
It's definitely a major issue in the UK, a really prevalent complication of diabetes.
Right.
The exact number, well, they vary a bit depending on the population you're looking at, how long they've had diabetes, how good their control is, that sort of thing. But generally, it's seen more often in people with type 2 diabetes.
More than type 1. Why is that?
Partially just because type 2 diabetes is much more common overall in the population.
Gotcha. And what would someone actually notice? What are the typical symptoms they might experience day to day?
It usually hits the central vision. So people might find their vision becoming blurred or maybe distorted, like straight lines appearing wavy. Colors might seem less bright, kind of washed out. And tasks needing sharp central vision, like reading a book or recognizing someone's face across the room, can become really difficult. Some people even get central scotomas.
Scotomas?
Yeah, like blind spots right in the middle of what they're looking at. And it's quite common for it to affect both eyes, though maybe not always equally.
Okay, so central vision problems are key. Is there a memory aid for the symptoms too?
We could try the 3Cs and a B.
Okay.
Think color changes, clarity issues like blurred vision, central problems like the scotomas, and difficulty with faces or books, meaning reading.
3 C's and a B. Color, clarity, central, books, faces.
Nice one. So when an eye doctor examines someone, what are they specifically looking for to diagnose this?
Right. So diabetic maculopathy can actually happen alongside both non-proliferative and the more advanced proliferative diabetic retinopathy.
Okay.
During the slit lamp exam, where they look closely at the back of the eye, the ophthalmologist is hunting for specific signs right in the macula. They'll look for thickening, for fluid,
Right.
and based on what they see, they might classify it. For instance, there's focal maculopathy. That's where you see distinct little areas of leakage, some swelling, and maybe those yellow fatty deposits, hard exudates, often clustered around tiny weak spots in blood vessels called microaneurysms.
Okay, focal.
Then there's diffuse maculopathy, which is, well, more spread out, more generalized swelling.
Diffuse makes sense.
You can also have ischemic maculopathy. This is a bit different because the vision might be poor, but the macula doesn't look that swollen initially. Further tests show that the macula isn't getting enough blood flow. It's ischemic.
Ah, okay.
Lack of blood flow.
Exactly. And then there's a really important category called clinically significant macular edema, or CSME. This has specific criteria based on how much the macula is thickened and whether there are hard exudates close to the very center, the fovea.
Clinically significant. Okay.
Yeah.
So it sounds like just looking isn't always enough.
Right.
What investigations really help confirm the diagnosis and, assess how severe it is?
Absolutely. So a full eye exam, checking vision, looking at the fundus after dilating the pupils, that's the baseline.
Standard stuff.
Yeah. But optical coherence tomography, OCT, that's become, well, indispensable, really.
OCT.
OCT uses light waves, a bit like ultrasound, but with light, to get these incredibly detailed cross-section pictures of the retina. It lets us measure the macular thickness very precisely and actually see the fluid buildup, quantify it.
Wow, okay. That sounds key.
It really is. Another very useful test, though maybe used a bit less now, OCT is so good, is fundus fluorescein angiography, or FFA. Yeah. Here, a fluorescent dye is injected into an arm vein, and then special photos are taken of the retina as the dye circulates through the blood vessels.
What does that show?
It highlights the blood flow and, crucially, shows exactly where the vessels are leaking dye into the retina. It maps out the leakage.
So you can pinpoint the problem areas.
Precisely.
Yeah.
So maybe think, see the flow and thickness. FFA helps you see the flow and leakage, and OCT shows you the thickness and the fluid.
See the flow and thickness.
Yeah.
OCT and FFA.
Got it. Another good tip. So once it's diagnosed, what's the management plan, typically in the UK?
Okay, the absolute foundation is managing the underlying diabetes and related issues. So getting blood glucose under the best possible control.
Number one.
Absolutely. Plus, really tight control of blood pressure and managing cholesterol and lipid levels. That systemic control is vital.
Right. Tackle the root causes.
Exactly. Then for the eye itself, especially for that clinically significant macular edema we mentioned, the first-line treatment now is usually injections into the eye.
Injections into the eye. Yeah. Sounds a bit daunting, but it's very common and effective. We inject medications called anti-VEGF drugs.
Ah, VEGF, the leakage signal molecule you mentioned earlier.
That's the one. These drugs block VEGF, helping to reduce the leakage and swelling. Steroids can also be injected, sometimes.
Okay, anti-VEGF first line. What else?
Laser treatment focal or grid laser photocoagulation is still used. It involves using a laser to carefully seal off the leaking microaneurysms, especially in focal maculopathy.
Right.
Sometimes laser might be combined with the injections, and in very advanced cases, maybe with things like scar tissue pulling on the retina, a type of surgery called vitrectomy might be needed.
Vitrectomy, okay.
But the key thing alongside treatment is regular monitoring. Follow-up appointments are crucial to track progress and adjust treatment. And of course, prevention is better than cure. Strict systemic control and attending those annual diabetic eye screenings are so important.
Definitely. So if someone with, say, long-standing type 2 diabetes and poorly controlled blood pressure comes in with blurred central vision, and they're found to have that clinically significant macular edema,
the go-to first step would likely be those intravitreal anti-VEGF injections based on current UK guidelines.
okay. That clarifies the approach. What are the long term? What's the prognosis usually like?
Well, it really varies. It depends quite a bit on how severe the maculopathy is when it's first picked up.
Early detection matters.
Hugely. It also depends on how well the eye responds to treatment and, critically, how well the person manages their diabetes, blood pressure, and lipids going forward.
Right. The systemic control again.
Always. With prompt treatment and good ongoing care, many people find their vision improves or at least stabilizes, which is a good outcome. But, if it's very advanced or if there's already significant ischemia or scarring, the prognosis might not be as good.
Understood. And what happens if it's not managed well or if treatment doesn't work? What are the potential complications?
Unfortunately, there are several serious possibilities. The most obvious is progressive vision loss, potentially leading to legal blindness. You can develop more widespread macular ischemia, which is really hard to treat. Tractional retinal detachment can happen.
Where the retina gets pulled off?
Yeah, due to scar tissue forming from abnormal blood vessels. And you can also get neovascular glaucoma, which is a severe type of glaucoma caused by those abnormal vessels growing in the wrong place and blocking fluid drainage from the eye.
Those sound pretty serious.
They are. It really underlines why early detection, getting the right treatment promptly, and sticking with regular eye care is just so vital. It minimizes the risk of these things happening.
Any final memory aid for those complications?
We could try vision loss is really nasty.
Let's hear it.
Vision loss, ischemia, macular, retinal detachment, tractional, and neovascular glaucoma.
Vision loss is really nasty.
Yeah.
VIRN. Okay, another good one. So let's just quickly pull that all together. Diabetic maculopathy. It's swelling in the central retina, the macula, caused by diabetes leakage. Yep. Biggest risks. Remember, LPHDRK, long duration, poor control, hypertension, dyslipidemia, retinopathy, kidney disease.
Got it.
Pathophysiology involves leaky vessels due to high blood sugar damage, plus inflammation and VEGF. Diagnosis relies on exams plus OCP and maybe FFA. Remember, see the flow and thickness.
Good summary.
Management is all about systemic control first, then eye treatments like anti-VEGF injections, first line for CSME. Laser, sometimes surgery. Regular checks are key.
Crucial.
And complications can be severe, so early action is vital to avoid. Vision loss is really nasty. Vision loss, ischemia, retinal detachment, neovascular glaucoma.
You've nailed the key takeaways there.
Excellent. It really brings home how important managing diabetes well is for eye health, which leads to a final thought, really. Given that diabetes is becoming more common, how can we actually get better at implementing preventative strategies and ensuring that everyone who needs it gets timely eye care? How do we stop more people from losing vision to diabetic maculopathy? Something to think about.
That's the big question, isn't it? And for anyone listening who wants to dig deeper into this or other MSRA topics, definitely check out PassTheMSRA.com.
And there's also freemsra.com for more resources.
Both great places to look.
Fantastic. Well, thanks for joining us for this deep dive today. Until next time.